in the bone health program in DC, and I also do work in fibrous dysplasia at the NIH with Dr. Collins, specifically with the natural history study. So I have two topics to talk about today. The first talk is going to be on bisphosphonates and denosumab use in fibrous dysplasia. And I'll spend the most time on that and then finish up with a short talk on the non-bone endocrine aspects of McCune-Albright syndrome. So bisphosphonates are medications that prevent bone breakdown, and they're specifically used to treat disorders that are associated with either low bone mass or high bone activity. And I put this picture just right here that shows the normal skeletal matrix. It's a picture of a low bone mass. So you can see there's decreased matrix present. That's the most common use for bisphosphonates. So bisphosphonates work by disrupting the bone remodeling cycle. So in the skeleton, all the time, bone is being built up, broken down, built up, and broken down. And there's two main cells involved in this. So this big, large blue cell here is called an osteoclast, or the bone chewing cell. So it lies on top of the cell and secretes acid and actually creates these holes in the bone. Then the osteoblasts, or the bone building cells, swoop in, they go to the hole, fill it in with extra bone, and smooth it over. So this process takes place continuously, and this is how bones are remodeled and also how bones grow in childhood. So bisphosphonates work because they're taken up by the bone cells and they're actually incorporated right into that skeletal matrix. And once they're in that matrix, they act by decreasing the activity of the bone resorbing cells, or the osteoclasts. So in a typical bone, what you'll see is there's a balance between the bone formation, or the osteoblasts, and the bone breakdown, or the osteoclasts. And by inhibiting the osteoclasts, what happens is you tip the balance of the bone remodeling cycle, so there's more bone being formed relative to bone being broken down. And the net result of that is that you have more bone, denser and stronger bone. So there's a lot of different types of bisphosphonates. They've been used for a number of years. Up here I just put the main kinds that you'll probably hear about and see in use currently. So there's two main formulations, IV formulations and oral formulations. Probably the most common one you'll see used in fibrous dysplasia is zoledronic acid, or Vclast. It's a 30-minute infusion, and it's usually given about every 6 months. A lot of people are on oral bisphosphonates too, especially for osteoporosis and other indications. Fosamax is a common one that's given once a month. So what types of patients use bisphosphonates generally? So the FDA has approved bisphosphonates for treatment of adults and for several specific conditions. So osteoporosis, so either that's low bone mass that can be associated with old age, menopause, steroid use, or other medication use, a number of conditions. It's approved for treatment of Paget's disease. So this is a bone disease of very high turnover, where the bone is very revved up, kind of like it is in fibrous dysplasia. It's approved for treatment of bone tumors, so either primary tumors that arise in the bone itself, or metastases, so tumors that travel to the bone from other sites. And it's also very helpful for treatment of high blood calcium levels. One of the main sources of calcium in the blood is actually chewing up of the bone that the osteoclasts do. So if you inhibit the bone breakdown, they're unable to release calcium out of the bone into the blood. So if a patient has high calcium levels in the blood for any reason, decreasing the activity of the bone cells can help treat that. So this list is really it. Any other use of bisphosphonate is considered off-label or not FDA approved. So it doesn't mean we can't use it. It just means that it needs to be given in the best interest of the patient in the opinion of the treating practitioner, whether or not it's not officially sanctioned by the FDA. So a major use of off-label bisphosphonates are in children. So any use of a bisphosphonate in children is off-label. And this is an important point because there's really a lot of different factors to consider when you give bisphosphonates, or really any drug that impacts the bone to kids. So kids' bones are very different than adults. The main difference is kids' bones are still growing. So they're changing in length, and they're also changing in shape. In general, kids have very different kinds of bone diseases than adults. So if I threw up a list of the most common bone diseases in kids, it's not going to look anything like that list of most common bone diseases in adults. They don't get old age osteoporosis. They don't often get Paget's disease. So it's really a different set of conditions that you have to worry about. And then potentially the most important point is that there are far fewer studies conducted in kids than there are in adults. And this goes far beyond use of bisphosphonates or far beyond even studies in bone. So conducting research in kids is just more complicated than it is in adults. There's more ethical issues, there's more regulatory issues, and frankly, kids just don't get sick as often as adults, so there's not as many pharmaceutical companies who are interested in studying kids. So we just have to get used to making medical decisions for kids without that same level of data that we're going to have in adults. So bisphosphonates are used in kids, and fortunately there have been some studies of bisphosphonate use in kids. Most of what we know about bisphosphonates in kids is due to studies in osteogenesis imperfecta, or brittle bone disease. So this is a very different disorder from fibrous dysplasia. This is due to collagen mutations, where the bones are very fragile and break frequently. But luckily we do have some good safety data from the studies in OI that we can generalize to kids with other conditions. So we know that in OI, the bisphosphonates don't seem to significantly affect the growth. Kids end up just as tall if they're treated with bisphosphonates. It doesn't tend to significantly affect the shape of the bones. They look relatively normal in shape. And it seems to be very helpful for treatment of bone pain in OI. It's probably, we don't have quite enough studies to know this for sure, but it probably decreases risk of fractures for OI. So in general, bisphosphonates are pretty close to standard of care for treatment of kids with OI, and most of us who see kids with this will start it in the severe cases even in infancy. This is what is a radiograph of a child who's treated with bisphosphonates, and this is an important point I think for parents to realize is something that's going to happen if children are treated. So the arrows are pointing to these sort of thick, sclerotic white bands across the bone. And this happens because the bone is still growing when it's given bisphosphonates. So if you smack down those bone-resorbing cells, at the place where they're most active in a child is right here where the bone is growing. So this is a knee. And every time you get an infusion, you'll get a line. They don't seem to cause any problems. They don't seem to break. If you stop the drug, like this patient did, as the kid grows, they'll travel farther and farther back. And eventually they seem to just disappear. But it is something to note because it can be a little startling to see on their x-rays that this does not happen in adults. So side effects of bisphosphonates, we know they seem to be relatively safe in a short-term period. These are most of the more common side effects, and they're all pretty manageable. Flu-like symptoms are common after the first 1 to 2 doses. This is temporary. It's usually manageable with Tylenol or Motrin. It's a good idea to take an anti-inflammatory medication before the infusion. Low blood calcium is something that you do have to look out for. As I mentioned, this happens because there's less calcium released from the skeleton into the blood. This is more common to happen in patients who are vitamin D deficient. So before anyone gets a bisphosphonate, before anyone gets an infusion, I check their vitamin D levels in the blood. And most people who are on this medication should probably be on a vitamin D supplement. Another thing that I think often gets neglected is you have to be getting enough calcium in your diet if you're going to take this medication. So any adults getting bisphosphonates need to be getting 3 servings of dairy per day, or the equivalent for a calcium supplement. GI disease can happen with the oral formulations of bisphosphonates, and this can actually be very severe. Patients can get reflux and ultimately ulcerations in the esophagus. So if anyone who is on an oral bisphosphonate gets any GI symptoms, it's important to stop the drug. And I actually don't even feel comfortable prescribing these medications to a child that I don't think is going to really be able to verbalize if they're having GI symptoms. So osteonecrosis of the jaw is a potentially serious side effect with bisphosphonates. It gets a lot of attention. It gets brought up a lot when discussing these medications. So it's a rare complication. It happens because there's interruption to the blood flow to the bone in the jaw. It really is most common in a pretty specific type of patient. So it's usually seen in an adult patient, frequently an adult cancer patient who's getting the medication for treatment of bone tumor. Often it's patients who are treated with steroids at the same time. And in general, it seems to be dose dependent. So patients who are on higher doses or on IV doses with potent bisphosphonates are more likely to get this complication. And also, for some reason, it really seems to be triggered often by dental procedures. So if anyone who is started on this medication, it's important to see the dentist and have any invasive dental procedures done before you start. Fortunately, at least for my world and for my clinic, it's never been reported in a child or an adolescent. We don't have enough data in fibrous dysplasia, given that it's a rare disease, to really know the risks in our patient population, but most of us have the sense that patients with FD don't seem to be at any higher risk than the general population who's treated with bisphosphonates. There's really only a few cases of osteonecrosis of the jaw that have been reported, and they've been in patients who've received very high doses of bisphosphonates for a really long period of time. So it's not a negligible risk, but it's a small risk, and it's not one that that would really make me hesitate to use this medication in someone I really thought needed it. So bisphosphonates and fibrous dysplasia, there's not a lot of data, but I would say that there's a growing body of clinical, practical experience. So when bisphosphonates first came out, there were a number of case reports published that looked really exciting. A lot of reports that the FD lesions seemed to look better on X-ray. They seemed to fill in. Patients were reporting much better, good, nice response with regards to pain. But as time went on, the excitement seemed to dull a bit. More case reports were published that seemed to conflict the evidence that it was helping the lesions and filling in the lesions. The one thing that seemed to be relatively consistent is most reports said that it does seem to help with bone pain. So there's really only one clinical trial, so one high-quality trial that's been conducted for treatment of fibrous dysplasia. That was one that was done in Dr. Collins' lab several years ago. And this was conducted with alendronate, which is an oral form of bisphosphonate. So it was two groups of patients, one treated with the drug and one treated with a placebo or a fake drug. And it was double-blinded, so neither the patients nor the researchers knew who was getting a real drug and who was getting a placebo. And the results were disappointing. We didn't see any improvement in pain with alendronate, and we didn't see any change in the appearance of the FD lesions. So this is just a representative X-ray from some patients treated in that study. So up here at the top, we have a patient who was treated with alendronate for 2 years. And you can see the ground glass lesion in the proximal femur. And after 2 years of treatment, there's really no subjective improvement. It doesn't look to be filled in. If anything, it seems to be a bit bigger. Same thing in the placebo-treated patients. We didn't see any real significant change other than what we would expect in the general progression of fibrous dysplasia. So this was a bit disappointing, but still important knowledge for us to gain. But in our clinical experience, we still do think there's a role for bisphosphonates for treatment of bone pain. So a number of other studies have looked at oral bisphosphonates and found that they don't seem to be as effective as IV bisphosphonates for treatment of bone pain. Specifically in OI, the IV formulation seems to be much more effective. We only use bisphosphonates to treat pain. I don't think there's any evidence to suggest that the bisphosphonates are actually getting in there at that FD lesion and improving the quality of the bone or improving the mineralization of the bone. So pain is really the only indication at this point. And as I mentioned, we limit our use to IV bisphosphonates. I don't recommend oral bisphosphonates in fibrous dysplasia. The bisphosphonates, they seem to be relatively effective. Most patients who are given an IV bisphosphonate will see at least some improvement in their bone pain. It seems to be more effective at improving pain in the body as opposed to pain in the skull. The skull pain is more resistant. It really seems to be trickier to treat. An important thing to realize is that it may take more than one infusion to start working. Sometimes we have to do a couple infusions back to back, almost like to get the pain in remission. Once you have it under control, then ongoing treatment is more effective. So I wouldn't give up if the first infusion doesn't work. One thing that really can be just surprising in this therapy is how variable people respond. Although most people respond, the pain will come back at different intervals for different people. We have really gone away from doing a set dosing schedule. You know, if you're using these medications for osteoporosis or for bone tumors, you'll see that the package insert says give this dose every 6 months or every 3 months. That's not how we do it. We really have listened to the patients and we repeat the doses as we need to based on their symptoms. And that may vary as their fibrous dysplasia varies. They're going through a period where they're having more pain, they may need more medication. And then as they age or as their physiology changes, they may need less. But our general treatment principle is we try to use the lowest dose at the lowest frequency that we need to treat the pain. So that's my summary of bisphosphonates. I'm just going to then segue into Denosumab, which is a drug that's similar to bisphosphonates that's really gotten a lot of attention recently in both fibrous dysplasia and in other areas. So Denosumab is an antibody that binds and inhibits a protein called RANK ligand, and we'll talk a little bit about what that protein is. It has a lot of similarities to bisphosphonates. It inhibits bone breakdown in a very similar way to bisphosphonates. It's also FDA approved for adults with osteoporosis and bone tumors similar to bisphosphonates. But there are some key important differences. It's a lot more potent than bisphosphonate. It's a much more powerful inhibitor of bone resorption. It's a lot shorter acting. So I mentioned that the bisphosphonates are incorporated into the skeletal matrix. They are taken up and are built right into that bone. So as the bone is broken down over years, bisphosphonates can be released into the bloodstream for years. So we can find evidence of medication still in the system after 10, 20 years after treatment is completed. Denosumab is in and out of the system after 6 months. It doesn't linger to the same extent that bisphosphonates do, which does raise the possibility of treatment reversal, which could potentially be a good thing. But a really important difference to bear in mind is there's a lot less data available for Denosumab treatment than there is for bisphosphonates. Less efficacy data, less safety data, and less long-term data. So RANK ligand is a protein, as I mentioned, and it turns on the cells that break down bone. So it turns on those osteoclasts. So you can see down here, it's bound to the surface of, this is the skeletal stem cell that Dr. Roby was talking about. You can also find it on osteoblasts, which are the bone building cells. And what it does is it binds to receptors on these inactive osteoclasts. And this turns the osteoclasts on to be activated, to then go on to break down bone. So Denosumab prevents this process. It interferes with the binding here at the level of the RANK ligand receptor and prevents bones from breaking down. So why are we talking about Denosumab and FTE? So why has there been so much interest generated? So I'm going to show a little bit of data that we have come up with in the lab, looking at the role of RANK ligand in fibrous dysplasia and the potential role of Denosumab. It's very preliminary. It is not strong enough data that we can go out and wave our flag and say that we've unlocked the key to fibrous dysplasia. Far from it. But it does seem to suggest that this is a line of research that's potentially promising, that's worth pursuing, and that maybe, if it continues to look positive like this, could potentially open the avenue for a treatment in a relatively short period of time that would be available. So we know that RANK ligand is found in bone from FD patients. So this is the histopathology, which is bone underneath the microscope. This is the FD bone. You can see all this very active fibrous tissue here. Here is that same bone with RANK ligand staining. So everywhere you see the brown dark is where an antibody bound to RANK ligand. So there seems to be a lot of RANK ligand present in FD tissue. And this is unusual. You don't see this level of expression in normal bone typically. So we know that RANK ligand seems to be found in blood from our FD patients. This graph here shows RANK ligand levels in FD and non-FD patients. So you can see in the non-FD patients, the levels in the blood are relatively low, and they are a lot higher in our FD patients, so this was statistically significant. Interestingly, the rank ligand levels seem to be higher in patients who had more FD. So this is a correlation line, and it's showing that as the bone scan score or the amount of fibrous dysplasia in the patients increased, their rank ligand levels increased accordingly. And then another thing that's really gotten us interested in looking at denosumab and rank ligand in FD is that it seems to be a very effective treatment for giant cell tumors. So these are different bone diseases than FD. It's a different process, but it involves the same type of cell. So it's also a tumor that seems to primarily result from an abnormal skeletal stromal cell, similar to FD. And as Dr. Berg mentioned, they look very, very similar under a microscope. You pull up two slides, one of a giant cell tumor and one of fibrous dysplasia, and even very good pathologists wouldn't necessarily be able to tell you which is which. So it's kind of a crude analogy, but it does seem to suggest that if neither process is understood all that well, but if you have a medication that works for one, it certainly seems at least worth considering in the other disease. So giant cell tumors are now denosumab is now FDA approved for giant cell tumors. The data was pretty convincing, and the FDA actually fast-tracked that approval process. So our actual clinical experience with denosumab and fibrous dysplasia, though, is very limited. We have treated about 3 patients at the NIH now, and in the medical literature, there are 3 additional patients who have been treated and published. So 6 patients is really a very small number. And of those patients, what we have seen is there seem to be relatively, so far, consistent reports of improvement in pain. And even in some patients who failed management with bisphosphonates. So it's possible that this might be a more potent pain medication for fibrous dysplasia. We're very interested to see if it could control some of the pain that doesn't seem to be well controlled by bisphosphonates, like pain in the skull. One concerning thing was that we saw mild to severe abnormalities in blood calcium and phosphorus levels in several of the patients. So that has also been reported in the patients with osteoporosis and bone tumors and all the other diseases that have been published in denosumab. But we're already seeing it in FD in only 6 patients. So what that suggests is patients with FD may be more vulnerable to calcium and phosphorus abnormalities in using this medication, which means we need to really be careful and figure out what is a safe way to give it. The effect on the FD lesions is not known. Only one of these 6 patients was really analyzed, looked at very systematically to see what was going on with a specific FD lesion. So this was a little boy that had a very rapidly expanding FD lesion in the femur, and the purpose of the denosumab was really to try to slow down growth of that lesion. Over 6 months of treatment, it did appear that the growth of the tumor may have slowed down, but again, one patient, very short-term study. So at this point, I think we do have to say we have no idea whether or not the denosumab will actually affect the FD lesions. So at this point, we have many areas of uncertainty. These are a number of the questions that we need to address. Does denosumab work for FD? If it does, what dose do we need to give, and how frequently do we need to give it? If you're giving this medication for osteoporosis, it's a low dose every 6 months. If you're giving it for giant cell tumors, it's a high dose every month. Who knows which one of those would apply? Who knows if we need to find some dose in the middle? Is it safe? What side effects might occur? How are we going to monitor patients for these side effects? And what happens when the drug is stopped? So the little boy that we treated developed very high blood calcium levels after stopping the medication. We're still not entirely sure why, but he required hospitalization. So I think we need to be very careful about using this medication and starting and stopping it with very strict monitoring in place. What happens to kids? We don't know if this medication will affect growth. It's a lot more potent than bisphosphonates. So just because bisphosphonates don't affect growth doesn't mean denosumab doesn't. We haven't seen any osteonecrosis in the jaw in children with bisphosphonates, but we might with denosumab, we don't know. Conveniently, a clinical trial in children with osteogenesis imperfecta has recently started. So personally, I would much rather see their data and see what kind of safety findings they find before I'm going to freely give this medication to kids with FD. So current state, where is the field right now in denosumab and FD? We are planning a pilot study in adults with FD to start at the NIH, hopefully in the next year. When giving the drug as part of a clinical trial allows us to really put more safety procedures in place, allows us to be a lot more rigorous about the type of endpoints we're monitoring for. We can check more blood levels, we can check more radiographic studies. So we feel that that's something that we can do safely in the context of research. But at this time, we don't recommend using it off-label in the general population, except in very, very rare circumstances. So a patient who has a very high risk of morbidity, like a very rapidly expanding craniofacial lesion, who might be at risk for vision loss. That type of situation, it may have a role, but I would be very careful, and I would give it only in the circumstances of practitioners who are very experienced in FD. It's the type of situation that we'd like to be involved with if possible. So I think I just used up my time for denosumab and bisphosphonates. So I think I will then briefly move into our endocrine disorders, and then I think we can do a wrap-up and take some questions. So I have about 15 minutes for endocrine disorders and McCune-Albright syndrome. They are quite a few. So I've really focused it mostly on treatment and on clinical pearls for parents and patients to know for their own health maintenance. So this is the list of endocrine disorders in McCune-Albright syndrome. So precocious puberty, hyperthyroidism, growth hormone excess, phosphate wasting, and Cushing's. And we've heard bits and pieces about these disorders throughout the day today. So this are the findings in our MAS patients at NIH. Most of our patients have some type of endocrine complication. But as we heard in the registry talk today, we don't know if this is representative to the entire population of patients with McCune-Albright syndrome. These are just the patients we've seen at the NIH. But still useful information. We know that that precocious puberty and hyperthyroidism tend to be the most common complications, that phosphate wasting is relatively common as well, and that growth hormone excess and Cushing's are really much more common. So precocious puberty, as I mentioned, is the most common endocrine disorder in girls, and it actually tends to be the presenting symptom in a lot of patients. In girls, it develops because they are transient ovarian cysts. So the ovary will periodically form cysts that overproduce estrogen, and then the cysts go away. And it creates this very confusing picture where patients will develop signs of puberty, breast development, they'll grow quickly, and then all of a sudden everything goes away, and there's an episode of vaginal bleeding as the cyst resolves. So it's what we call a recurrent relapsing course. In boys, who are much less commonly affected, the precocious puberty tends to be a steady process with sustained levels of testosterone production. So our goal in treating patients with precocious puberty is really to prevent short stature in adulthood, which may sound strange when you see a patient with precocious puberty, because usually they're one of the tallest kids in their class. The hormone levels cause them to accelerate in their growth and to grow very rapidly. But what it also does is mature the bones. So the growth cuts off sooner than it's supposed to. And the final adult height tends to be relatively short. So that's our primary goal. That's the main complication we want to prevent. But it's also nice if we can prevent the bleeding episodes, which can be distressing to patients, and the signs of sexual development. And in particular, we want to prevent any social or behavioral issues that may come, or discomfort that may come from having high levels of hormone production in a young child. So one of the most important things to take home for the treatment of precocious puberty is to not let anyone operate on your child. We have a large number of patients who have had cysts removed surgically. And it makes sense. You see a child with high estrogen production and an abnormal area of the ovary. It's often the doctor's first instinct to go in and take out that problem area. And it will work temporarily. But the problem is, it doesn't address the underlying problem, which is that GS-alpha mutation. So the cyst will just continue to come back. So you won't have altered the course of the patient's development. You won't have helped them at all by removing that cyst. So avoid surgery if at all possible. So there are a number of medications which can be very effective. So letrozole is our preferred medication for treatment of girls at NIH, and this prevents estrogen from being formed or being converted from its previous form. There are other medications that can block the action of the estrogen, tamoxifen, tamoxifen and fulvestrant. And in boys, there are a number of medications that can block the action of testosterone. So in general, these medications used either alone or in combination with each other can treat precocious puberty in most kids. We've had very few treatment failures. But an important piece for parents to bear in mind is this is only going to be temporarily effective. The precocious puberty in McCune-Albright syndrome happens because the sex organs are operating without permission. They're turning on after a few years of that, after the body has those sex steroids floating around in the child for a number of years, the brain will start to, and the pituitary gland that controls puberty will start to think, maybe time for me to wake up. There's all these hormones around. The pituitary gland will wake up and will then cause you central puberty, which is a different type of puberty. So it's also very treatable, but it needs to be treated with a separate medication. So what you'll typically see is your child will have well-controlled precocious puberty for several years, and then it'll look like the treatment is starting to fail. That's time to take them into the doctor and see if they've developed central puberty, see if they need an additional medication. Hyperthyroidism is probably the second most common endocrine complication in McCune-Albright syndrome, and it arises because the thyroid gland is overproducing thyroid hormone. The initial first-line treatment is methimazole. So this is an oral medication that's given twice a day. It's very effective, works in most patients. There are rare but potentially serious side effects with this medication that need to be monitored for. Patients need to have their liver tests checked periodically and their blood counts checked periodically. And because of those side effects, most people elect not to stay on methimazole permanently. Most patients will proceed with permanent treatment for hyperthyroidism, which our recommendations are surgical removal of the thyroid gland. That's something you usually want to wait a bit for. It's a technically difficult procedure, and it's one that should probably not be done in a very young child. So we generally start thinking about it around age 10 or above. And a very important thing to recall is that you've got to use an experienced endocrine surgeon. So you want to go to what's called a high-volume center where lots and lots of thyroidectomies are done, because it's been shown that better outcomes will result when surgeons are experienced in performing this. You never want to be someone's only thyroidectomy. Growth hormone excess is an uncommon but potentially serious endocrine complication. The important thing to know about is and this results because the pituitary gland in the brain is overproducing growth hormone. This complication is very important to diagnose and treat early, because if it's not treated, it can increase the expansion of the craniofacial fibrous dysplasia, and we have seen in our cohort that untreated growth hormone excess is associated with vision loss. And this is due to compression of these optic nerves. So here's the CT scan, here are the eyes, and these are the paths it travels through. So medications seem to be relatively effective for this. Our options are octreotide, which is an IM injection once a month, and pegvisomant, which is just a subcutaneous injection once a day. Most patients are controlled on either one or both of these medications used in combination. So if medical management fails, this can be a very difficult endocrine complication to treat because we don't have other good options. So surgery can be performed. You can go in and remove the abnormal part of the pituitary, but it's technically very difficult. You've probably heard a couple times today that fibrous dysplasia tends to bleed a lot when you perform surgery on it. And the pituitary gland is really located right here, right in the middle of the brain. It's not a good place to bleed. And because of the way the abnormal growth hormone producing cells form in the pituitary, the only way you can control this is to remove the whole gland. So someone's going to be left deficient in a number of different hormones, and it's going to have to be on replacement for not just growth hormone, but a lot of different hormones. So it's not an ideal option. The other option is radiation therapy. So this can be very effective at controlling the growth hormone excess, but it unfortunately carries a risk of also radiating the fibrous dysplasia that's near that pituitary gland. And there have been reports of transformation of the fibrous dysplasia into cancer because of being caught in that radiation beam. So both options that are very difficult and should be undertaken with someone who's truly expert in management of fibrous dysplasia and growth hormone excess. So phosphate wasting is an endocrine disease that arises because the FD bone itself. So the abnormal cells in the FD bone overproduce a hormone called FGF23. And this is your main phosphate controlling hormone in the body. And this causes the body to dump too much phosphate into the urine. As we've heard a few times today, this increases both fractures and bone pain. What it causes is it gives you another bone problem on top of your FD. So this is a nice abstract to illustrate this. So we see this is a femur, and here we have the ground glass FD. But if you can appreciate down here at this knee joint, you see the growth plate is just really ratty and not eaten and chewed up. That's rickets. That's just old-fashioned rickets where you see the pictures of kids with bow legs from vitamin D deficiency. So that makes the bone even softer and can make even the areas of normal bone can become weak, can become deformed. So it's really, really important to catch this and really important to treat it. Unfortunately, it's kind of an irritating endocrinopathy to treat because you have to give phosphate replacement between 3 and 5 times a day. It's important when you treat with these medications that patients have to be monitored for high urine calcium levels, so make sure your doctor is checking your child's urine. Another important point, we've seen a few people get into trouble because the dose of the medications is different in an active kid versus a kid who's immobilized. So if you're on phosphate and calcium trial and you go in for orthopedic surgery, you want to stop the medications while you're immobilized because you can actually develop high blood calcium levels. One positive thing to note, though, is that phosphate wasting is one of the few endocrine conditions that can actually improve or even go away with time. We have seen patients manifest phosphate wasting during periods of rapid growth when their bone really needs a lot of phosphorus to grow. And then in adulthood, when the bones are quieter and they're not growing, the phosphate wasting and the need for taking the medications may actually go away. So what initial testing should be done to diagnose the different endocrine conditions? So for the thyroid, you need to both look at blood tests and the ultrasound. Not everyone with thyroid disease will have excess thyroid hormone levels. Sometimes they'll just have structural problems in the thyroid, cysts or other abnormalities. And you'll want to know if those are there. So an ultrasound is a very important part of the evaluation. So for the phosphorus plate, you need to look at both blood and urine phosphorus levels. Growth hormone can be evaluated with an IGF-1, a blood level. If this is abnormal, there are other tests that need to be done, including a glucose tolerance test as a confirmatory test, and if needed, an MRI of the pituitary. Cushing's, I didn't spend a lot of time on Cushing's because it's a very rare complication. It occurs only in kids under age 3 years. We don't recommend routine lab screening for this. It's just a matter of monitoring patients clinically and seeing how they're growing. So ongoing monitoring for all endocrine conditions in kids with McCune-Albright syndrome, it really comes down to the growth chart. Every single one of these endocrine problems will alter your growth. You will either grow too much or too little. So it's really important to keep very accurate growth records, and it's important to present to a doctor for a child at least every 6 months so that the growth is being monitored appropriately. For precocious puberty, as we mentioned, because the final height is our most important endpoint, bone age x-ray to see how mature the bones are needs to be done periodically. For thyroid disease, it's monitored with blood tests, growth hormone excess blood tests, and for phosphate wasting, blood and urine phosphorus levels. Also, what you may notice if phosphate wasting presents is that patients will feel very fatigued and will have bone pain. So if you develop those symptoms, it may be a good idea to have a phosphorus level checked to make sure that that's not the reason. So follow-up really depends on the issue. Patients with stable disease can follow up twice a year. Patients with uncontrolled symptoms or on certain medications should be seen more frequently, particularly in childhood, so every 3 to 4 months as needed. So, thanks for your attention, and it's been a very long day. I'm very happy to take any questions.
So in your presentation, you mentioned about the bisphosphonates. So you don't recommend using it unless there's pain involved at all. My daughter, they put her on it, and she might not have to have surgery anyway. So But what about supplements? Like calcium supplements, should they always be on that? And checking all those things?
Yeah, that's a great great point. So I'm glad you brought it up. So, you know, even though fibrous dysplasia is kind of an exotic bone disease, we really want to make sure that you're addressing the basics of bone health.
Right.
So that is calcium intake, vitamin D. Really, it goes very far in promoting bone health.
What vitamin D level would you recommend? I know there's like 35 milligram, or should be up like 100 or something.
Yes, so much debate.
I've heard so many different radio programs and
yes,
things.
And no experts can agree. So I can tell you what
What
I
do you think?
what I do. So I think for a kid who has risk factors for fracture.
She's 19, so I'm
So anyone who has a risk to their bone health, so fibrous dysplasia, on steroids, rheumatologic condition, anything, I like them to have a blood level of at least 32. And most people can get that by taking about between 1,000 and 2,000 units of vitamin D per day. But most people do need to be on some type of vitamin D supplement to get to that level.
Okay.
Unless you really live in like sunny tropical paradise, most people need a supplement.
Oh yeah, that's
So you
right.
take 32.
32. Now, calcium supplements are different. They are not, there's a lot of debate about these two. There is not firm evidence that calcium supplements benefit bone health significantly. We really prefer to get calcium from the diet if you can. So the general rule is for kids between 9 and 18, they need the equivalent of 4 servings of dairy per day. It's a lot. Adults need 3. If you can't get that, then I do think it's reasonable to take a calcium supplement, about 500 milligrams at a time. But I really, especially if you have a kid and you have this opportunity to try to guide their diet and really try to push the natural
The other
calcium.
thing too is we don't strictly stay with the orthopedic and so on. You know, in the city, we went a couple of places, wound up in Sloan Kettering in the end, which did where they did the surgery. Orthopedic, very good. We're very happy with them. But should we also be, along with the orthopedic, should we also be seeing endocrinologists too? And because we haven't done that, and that wasn't recommended, and I kind of want to do, but I don't want to maybe insult him. I'm worried about the doctor, but you know, I felt confident in him. I entrusted my daughter's care in his hands, but. Should endocrinology be seen in conjunction with the orthopedic?
So she has polyostotic?
Yeah.
And has she had a full endocrine workup to see if
He did blood work at the time. I don't think it was full, I don't believe.
We
Yeah.
do recommend like a staging evaluation. So kind of a head to toe look to try to define what endocrine disease is there. How old is she?
She's 19.
Yeah. So, you know, probably at this point the only thing that could have potentially been missed would be thyroid disease. The subclinical thyroid disease is not associated with actual overthyroid production. But I do think it's important to pick that up because you're going to want to know if there's a lot of abnormalities in that gland because you are going to want to make sure that it's monitored regularly to make sure it doesn't develop nodules or other problems.
Does she have a lot of bone?
You mean the polystaltic?
Yeah.
She has it in the elbow, mainly in the hip and the femur, and a little bit in the tibia. The femur is the main area.
So you want, and her phos should be checked too. You'd be surprised how often that can get missed.
Really?
Because it's just a slightly low phosphorus doesn't always get people excited if they're not actively looking for it.
Okay, so I should take it to endocrinologist. Get good work.
Yeah, and maybe they could give you like a monitoring plan of
Right.
okay, twice a year check a vitamin D.
All right, thank you.
Speaking as a loyal opposition on your vitamin D statement, and prefacing that with there's absolutely no science to the vitamin D levels whatsoever. If you take that the normal distribution was on a two-tailed t-test, 2.5% too high, 2.5% too low, then you got 30 and 100 as the limits. If you, first of all, those are done on Midwest kids, which may have been low anyway, the curve may be skewed down. If you check vitamin C levels on the British Navy in the 1600s, you get a bell-shaped curve with everyone having scurvy. Okay, so the normal would be a normal for a scurvy patient. Now, if you assume there is no too high, it should have been a single-tailed t-test, 5% on the bottom, which would raise your lower level up to the 50s. A lot of people are assuming that you should be up maybe 50 or higher. Whether you assume a one-tailed or two-tailed t-test, I've only ever seen one documented vitamin D overdose report. Family out of Turkey were getting, kids between 8 months and 4 years of age were getting 800,000 units a day. Okay, so when they were come see me, they brought him in, IV, saline, Lasix, did fine. So there really is no toxicity on the upper end. The lab will list potential toxicity.
Oh, I
But
don't
will
know.
not list toxicity. So why push for 30? Why not push for 80 or 90?
But can I suggest something?
Yeah.
Fortunately, the good Lord gave us a measure of what the normal vitamin D level should be.
Which is?
It says you need to know the vitamin D level at which parathyroid hormone starts to go up. That's when the body is saying the vitamin D level is too low. And that level is 32.
Which is where I came up with 32. The actual Institute of Medicine defines 20 as deficiency, and I think that's perfectly acceptable for a kid without other risk factors. But we raise the bar a little higher for kids with FD. And it's not that well established by evidence-based medicine.
And vitamin D affects more than just bone and parathyroid hormone.
Yeah. But remember what we said about how if you're going to take care of kids, you just have to deal with bad evidence. So we have to pick a vitamin D threshold. So
I agree. If you go that higher, you're going to be fine too.
Yeah.
And the orthopedic rule, 1 is good, 2 is better, so use 3.
Whoa. Isn't it also the enemy of good perfect?
How do you get more data on Denosumab? I know you say six patients, data from that, but I do read on the internet other endocrinologists, different institutions that are trying.
Yeah.
So how do you gather the information so we know what the side effects are, what the benefits are from other institutions?
So that's why we want to do the pilot study, because it can be useful to hear, what we call anecdata from other institutions, what other people are doing, but you don't know how rigorously it's being given, you don't know how rigorously patients are being monitored for side effects. So that's one reason we do feel responsibility and a real motivation to do this pilot study at NIH. And we're not going to know based on that pilot study if Denosumab works for fibrous dysplasia, but what we're hoping is to get some safety data to get a better idea of what kind of dose we want to do, to then be taken forward into larger studies that will be more definitive.
So I guess carrying off of that, you mentioned there's so much uncertainty with dosing and what works and fibrous dysplasia versus cancer disease or anything else. And so I guess I'm wondering, if you have been on a certain dose, there's an Denosumab and alendronate and still have really no change in my outblast or bone rate. But how do I, instead of just giving up and saying they don't work, how do I know that it just wasn't the right appropriate dose?
Exactly.
I need to return to that instead of just going down some other route.
Exactly, and I think that's why we have to do things like pilot studies. So, that's why things have to, we have to do studies rigorously so that we are really, what you often do is you pick a dose and you try it. But if you're studying it rigorously and you're following the endpoints that you want to follow and you're gathering the information that you want to get to see how patients are responding, you can at least know this dose works or this dose doesn't. But if you just kind of try stuff, you won't know if it doesn't work because it didn't work for that patient or if it wasn't the correct dose.
But I would say that if before treatment your alkaline phosphatase level is high, and you take Denosumab and it doesn't lower your alkaline phosphatase level, you didn't take enough of Denosumab or whatever.
Yeah. So
it should lower the alpha phos too. That should be some measure of whether the dose is right or not. It may not take your pain away.
yeah,
If it lowers the alpha phos and your pain doesn't go away, then it might not.
it's a good point. It lowers it in everybody.
So then on an individual treatment base, could my own endocrinologist just try it? He doesn't have to have a clinical trial backing it. He can individually say, let's try raising.
Yeah, so that's part of the off-label reference I meant. So really, to put it kind of bluntly, any licensed medical practitioner has a lot of flexibility to give drugs that they think are appropriate for their specific patient and to give it in different ways, as long as they're really using their best medical judgment.
And they're aware of some of the potential risk factors of the low blood calcium, low blood phosphorus while you're on it, and high blood calcium when you go off.
Yeah, we were shocked to see that high blood calcium when we stopped our patients denosumab. There had not been anything like that reported in the medical literature. Since then, subsequently, we've heard of like 1 or 2 other people that have had similar reactions, but you know, the problem is it just hasn't been studied in patients this young and patients with this type of bone disease.
And similar reactions even in other bone diseases. So it looks like it's universal, not just
I'm going to throw one more thing into what Mike said. Even though it's not a study, even though it's one person treated by one doctor, that I think it's important that at the outset, not only do they know about the side effects, but that you and the doctor set specific goals for the treatment. And if those are specified at the beginning, and then along the way you can see if you really got there or not. Not, well, maybe I feel a little bit better.
Yeah, like we will see at 3 months how you're responding. And if you have not, we will increase the dose or stop. Sorry.
Just wondering, on those original 6 patients, how many of them actually had facial cranial skull pain as opposed to the long bones? Because you seem to indicate that maybe it was going to have a better result than bisphosphonate. How many of the 6 were actually?
I don't know. So, do you know?
I don't.
I don't. I think at least 1 or 2 though.
Okay.
I have a question for Dr. Lindemann and Dr. Stanton. With respect to rodding versus plating, what considerations are there for either?
I'm a big advocate of rodding because biomechanically it seems to share the load better. With a plate, you're relying on a cantilever stress, and the bone, the fibrous dysplasia bone, will relentlessly continue to bend. I guess I'm talking legs now.
Yeah, I remember last time you mentioning that the stress bend.
The stress on the hip is off the axis of the femur. So any stress on the lateral surface of the femur will be a cantilever levering type stress. With the rod on the inside, you avoid that. By having the plate on the outside, and I'll show tomorrow the fracture at the end of the plate from the stress riser, plates pulling off.
But is there any consideration that sort of says, no, you shouldn't do rodding and you should do plating because of something related to your bone or something?
It's more just device availability and technical, okay? That number one, the correct size intramedullary rods for exactly what we want to do are still not exactly available, okay? They're available to put the bone back together in the orientation of a normal kid, but we don't want that. We want people to be up in what we call valgus, and the rods are not available to do that. So there are
I'm kid-sized, so
Pardon?
I'm kid-sized, so I'm probably good.
Well,
but
in a young adult, the rods are available again to put things back the way they're supposed to be, and intramedullary rods are preferred. Okay, and the plates and screws are used because there's so many different ones of those available, and they're more adaptable to smaller children. But as he said, the plates and screws rely on strong cortical bone, which the patients don't have, and they do have to support this cantilever vector of force, which causes them to come loose over time. So they're not the perfect long-term solution, where intramedullary rods are much better.
Rods are better. We can put where we can put rods is limited. With plates and screws, we can put those anywhere.
I was studying
What's that?
Adults. So there's just so much more safety data, more data in adults. So there really hasn't been no clinical trial conducted in kids yet, other than this one that recently started in a while.
It's scary that
No, I'm saying the ones that you want to start, you start.
Yeah, we're going to start the pilot study in adults, but I do think that if this medication is effective, the real target population that we want to look at would be children. I think what we really need is an intervention that will prevent the lesions from expanding, prevent them from spreading. So the ideal target population would be young children. You got to start in adults for all the complicated ethical regulatory issues. And we do hope they'll be helpful for treatment of bone pain in adults, particularly pre-medication.
Is there any treatment that's like specific for the pelvic bone?
Not medical.
Pain-wise?
Or pain situation?
all the time. She's on a bisphosphonate IV. She's had 2 of them in the past year, and it helps like with her femur, but her pelvis.
She's on the refast?
First she did the peniginate, and then she did the solagenate.
You know, whenever there's a good pain response to a drug to some of the bone, but a specific bone is still hurting, I always wonder if it's not a surgical issue. It shouldn't be. If it's pelvis, you might even need a CT or something to see what's going on.
You talk about the pelvis?
Yeah.
Yeah. Well, I mean, that's another place where you can get an aneurysmosis, so you can't treat that with drugs.
And it also could be a microfracture through the acetabulum or the iliac wing, and you can't treat that.
Yeah, I would say you definitely want to rule that out, but some of it might depend on how close together were the infusions.
One was in October, the next one was in May.
So they're pretty far apart, and I guess it would also depend on what dose you want to make sure you use. Because most of us feel like zoledronic acid probably works better than pamidronate. So maybe another higher dose of zoledronic acid would be worth the try if you've ruled out things that are structural or surgical.
Also, I'm going to put a picture for Dan, the research. The pain history is important. It's really important to understand what the details of the pain are, so you can really come to a rational understanding of what may be going on. In fact, the need to the proper imaging and decisions about surgery or rehab or whatever is because pain is not all the same.
One thing that was brought up in discussing with some of the patients here, and I experienced myself, is you talked about the metabolic factor of the pain, the growing tumors and stuff, and the mechanical, fractures that are amenable to rods. You also have muscle that's hooking on to very rotten cortical bone. And when I was trying to rehab lengthening once, I got doing some single leg standing for balance, and immediately after about the 3rd time, right where the gluteals hooked onto the trochanter, got really sore because you had muscles pulling on eggshell bone, and you say, okay, done with that, can't do that. And you may have the same sorts of thing, and we don't have an answer for that. Just a rotten periosteum, rotten cortical bone.
Yeah, and Dr. Paul will talk tomorrow, but I do think that rehab and physical therapy are huge components of management.
So I have FD, and last year I had half my thyroid taken out for hypothyroidism, and then this year in July I had the bisphosphonate treatment. And then I found out 2 weeks ago that now I'm hypoactive. Do you think that's at all related to the bisphosphonate treatment?
Yeah, probably no. It shouldn't be. So we do know that any the surgical treatment for hyperthyroidism, like thyroidectomy, usually results in hypothyroidism. But hypothyroidism is so easy to treat. Medication, it's once a day. Thyroid hormone is very, very safe. It's a much better option than being on methimazole long term.
Yeah. Okay.
I have to stray away from these topics real quick. See, I have to consult pediatric endocrinologists, and I just don't know how to ask them what to get. So what do you really recommend that my 6-year-old daughter gets as a basic fibrous dysplasia, as a basic F patient that has craniofacial?
Yeah, so is in a workup to look for other signs of McCune-Albright?
Well, we wanted to do a bone scan, and so I also want to consult the endocrinologist. So what do you recommend would be my primary?
Yeah, we do have a document that we often share with practitioners to help them understand the screening process, but it essentially boils down to you want to bring a growth chart with you because we're going to be very interested in the rate of growth. So if you can get that from a pediatrician, it'll be very helpful. And then it's a matter of blood tests looking for the thyroid growth hormone, phosphate, and the thyroid ultrasound.
So get those. Even if, like you said, if the normal thyroid levels are fine, you still want an ultrasound.
Yeah, I think particularly it may be helpful for your daughter because if it looks like a McCune-Albright thyroid that can be diagnostically helpful, that would suggest that it may be fibrous dysplasia that's in the skull. So the thyroid ultrasound is an important part of the workup.
In the zoledronic acid treatment, there was a lot of physical dyscomfort. Is there anything that can be done in that regard?
You mean in response to getting the infusion?
Well,
Yeah, I think he's.
Yeah, my daughter,
Just
they had
the whole
very
week after those infusions was
hard to know. So the acute phase reaction, that flu-like reaction, it's pretty common after the first. Not completely uncommon after the second. I very rarely see people farther out than that. So you want to be really sure if you're not developing low blood calcium levels, because they can present with kind of aching muscles, twitchy muscles, nausea. So a lot of people will do labs 48 hours after the infusion to check the calcium levels. Because that's a reaction you wouldn't want to miss. Did you have blood drawn afterward? Yeah, that's where my money would be. Were you drinking a lot of milk? See, most people your age are not. So
the question is, were you drinking?
What were you drinking?
I guess how, like in those instances, because not all of us have, we're all being seen across the country and we're seeing the best person available to us, but even at that, they might not, think, okay, like I should probably check this kid's calcium right away, or, I guess how would you recommend patients or parents of patients approach their doctors so you don't feel like, I'm not telling you how to do your job, but I just want to make sure.
We do have our scientific advisory council. I'm with the Fibrous Dysplasia Foundation. I just looked just to make sure, but we do have recommendations on the website that you can print, and you can let them know that this comes from a group of scientific advisors who are involved in studies, so maybe I don't know.
Yeah, and don't be shy to advocate for yourself. I really do think that most doctors, when they see someone with something rare, if that person comes in and has, information or, strong opinions or information from other practitioners, most of the time they're grateful, So, bisphosphonates are a pretty common medication to use. So if you find someone that has an interest in bone, it doesn't have to be fibrous dysplasia. I use a lot of it for OI and other things. But in barring that, really coming to meetings like this and just telling them, if you have information for them, they should be open. But it's hard. It's hard.
Yeah, well, my physician, I feel like is actually, really great, and I know he's worked with fibrous dysplasia in the past, but it's some little things like that that, that should be checked right away.
And most of us that, who are listed on the website or to come to these meetings are happy to field emails and calls. You can certainly give my information to any of your doctors. We're happy to guide them on these types of things. But I can tell you for zoledronic acid, what I do is I put people on calcium and calcium trial at the same time as the infusion, and I check their labs 48 hours later because of low blood calcium.
Do they have you take supplements of calcium with the infusion?
Yeah, I bet that's
You don't drink milk at all.
You're ready. What's your vitamin D level? Because you avoid the sunshine.
That, when you mentioned that,
You avoid the sunshine.
I've been on about 7,000 IUs, and I still can't get over 30.
Really? That's a lot.
Get on 10,000.
And I live in Minnesota, so
Yeah.
I'm in the Midwest.
You need to move.
I've gone to checking every kid over by age 5 or 6 that's into the office for any reason. I'm running 95 out of 100 below 30.
Yeah.
During the winter, I will get some that'll come back too low to measure.
Yeah.
Single digits.
Yeah.
And I have to get them, on 5,000 or 10,000 units a day to get them up into the 30-40 range.
Yeah.
I'm not pushing for 80s, 90s. I'd like to, but
Yeah, no, it's tough because it's frustrating too when you see a patient who has, we can't fix the fibrous dysplasia, we can't make it go away, but we can sure make sure you have normal vitamin D levels. So it's really frustrating when you see someone who's had years and years of vitamin D deficiency because nobody checked.
Are there vitamin D shots?
There used to be. It's a very good question. There used to be something called STOS therapy that you could give like 100,000 units in one intramuscular shot, and it was mainly designed for little kids with rickets, but they're not available in the U.S. anymore.
Is it an absorption issue that why their levels will not go up?
So I'll tell you, I think the way a lot of practitioners have been repeating vitamin D isn't very efficient. So there's these 50,000 unit tabs that people are told to take once a week. I don't think it works very well. I think people
You have to take it.
Yeah.
And that's 7,000 a day, and all the adults, I get on 10,000, because if you check them, they're all going to be in the teens, and 10,000 is going to bump them up maybe to 40s or 50s. And rather than shoot to just get them up where they're just avoiding disease, I'm going to kick them way up. And in about 3 or 4 months, you go, I keep forgetting. I was on it, but I forgot.
That's why I asked if there's a shot. I don't do anything with regularity. It's a.
But don't forget the dietary calcium, because you can have the best vitamin D in the world, but if you are consuming no dairy and your dietary calcium level is in the toilet, then what's the point of having a good vitamin D level? They're really two sides of the same coin.
And vice versa.
You don't forget little fishes and stuff like that too.
Yeah.
As well as the
Sardines.
small fish, like sardines and things like
Yeah.
that. Will give you some
They
calcium.
have like 100 milligrams. Milk has like 300 milligrams. You have to have a lot of those fish.
I just like the good old needle. Give it all in one needle.
Yeah.
I don't do any dairy.
Wondering why you would say vitamin D
Yeah.
units, why you thought that wasn't a good idea? I mean, I happen to take 50,000 units twice a week.
Yeah.
It's called that.
Okay.
It's fine. It's certainly fine for some people. I just don't think it's absorbed that well in such a big amount. So some people aren't able to get their levels up. But if it works for you, if the blood levels rise, great. Just some people have multiple courses of it.